My name is Matthew Rettig. I'm a professor of medicine and urology at the David Geffen School of Medicine at UCLA, where I serve as the medical director of the prostate cancer program. So when one is approaching a patient with prostate cancer, one of the key initial questions is whether or not the patient is castration sensitive versus castration resistant. So I think it's probably easiest to define castration sensitive as one that is not castration resistant. So to define a prostate cancer as castration resistant, essentially there are two elements that need to be met. One, the patient must have a castrate level of serum testosterone that is less than 50 nanograms per deciliter. And what we're talking about there is the total testosterone, not the free testosterone. And the second is that the patient has some measure of disease progression. Now, most commonly, disease progression will be manifested by a rise in PSA, although in principle, the patient can have one of two other manifestations of disease progression: clinical or symptomatic progression or radiographic progression. However, in the overwhelming majority of patients, patients progress to castration resistance by a rise in PSA. And the rise in PSA precedes radiographic progression or symptomatic progression. And depending upon the state of the disease, that lag between PSA progression and either clinical or radiographic progression can be months or even years. So for patients who have castration-sensitive prostate cancer, those are the patients who don't have castration-resistant disease. So typically, this is a patient who is first going on castration-based therapy. They're defined as castration-sensitive, even though they have not actually exhibited a response to treatment yet when you're first starting treatment. But it's assumed that those patients are castration-sensitive. An alternative term that's used is castration naive or hormone naive. All these terms have the same clinical meaning. So when distinguishing castration sensitive from castration resistant disease, you have to look at one, the serum testosterone level, make sure that the patient has a castrate level of testosterone of less than 50 nanograms per deciliter, and two, has some measure of disease progression, which is most commonly PSA progression, but it could in principle be a clinical or radiographic progression. Situations where clinical or radiographic progression either occurs concurrently with PSA progression or precedes it would be those patients who have very advanced prostate cancer, typically have been metastatic disease and have been treated with hormone therapy for quite some time and have rapid disease progression. Again, it's really uncommon for patients to have isolated clinical or radiographic progression in the absence of PSA progression. So that's how I defined metastatic castration sensitive versus metastatic castration resistant disease and how I distinguish them.